Hi everyone, welcome to Blumberr Podcast, where we bring you conversations with people shaping the future of healthcare through innovation, expertise, and impact. Today's guest is someone who has transformed the landscape of head and neck cancer surgery in India. Joining us is Dr. Narayana Subramaniam, lead consultant in head and neck surgery and oncology at Aster International Institute of Oncology, Bengaluru. With over 5,000 complex surgeries, pioneering work in jaw reconstruction, robotic surgery, and skull based oncology. Dr. Narayana is internationally recognized hard for dealing with hard cases, some of the most challenging cancer cases, often helping patients who have been told that surgery may not be an option anymore. So that's Dr. Narayana Subramaniam. Welcome on board, sir.
Thank you very much for that kind interaction and introduction. Happy to be here.
Thank you so much. So, head and neck oncology, it's considered one of the most technically demanding practices in surgery. What drove you towards this?
So, a couple of things actually. So, I think head and neck oncology is an interesting specialty because it's at the confluence of many things, right? So, for people who are listening who don't know, what we call head and neck surgery basically is below the skull base, which means everything below the brain and its coverings, and everything above the clavicle or the collarbone. So pretty much everything within that realm is something that we treat potentially. It's at an interesting area of medicine because it has a lot of multidisciplinary input. What I mean is, I'm a general surgeon by background. I have ENTs who I work with. I have maxillofacial surgeons who I work with. We have to collaborate very closely with plastic surgeons, neurosurgeons, cardiothoracic surgeons, prosthodontists who help fabricate teeth for patients who need them, swallowing therapists. So it's an interesting confluence. So I was a general surgeon, and it just so happened that a friend of mine, a close friend of mine, told us that there was a very well-known head and neck oncologist who was visiting, and they'd be doing some surgery. So I went across and I had a look, and it was fascinating. So what I saw was a young girl who had a frontal osteoma. So she had a benign tumor that was involving the frontal sinus. So he did what's called a bicoronal approach, which means basically he lifted up the scalp like a flap, brought it down, and then he did a transillumination, which means that he put a light up against the frontal sinus to give an outline of where the tumor was, drilled it out carefully, put everything back and stitched it up. So we finished that operation. It was very interesting to me because there are many parts of it, right? So one thing is that you remove cancers. If you are trained, you reconstruct as well. So you reconstruct those defects after you remove the cancers. There's an interesting concept of, what we call craniomaxillofacial surgery. So that means moving different parts of the face and putting it back with plates and screws and things like that. So for me, seeing the patient on the table and then coming back a few hours later with the patient was, sitting up like nothing had happened, for me, that was transformational. So at that point, I decided I might be a general surgeon. I might know absolutely nothing about this specialty, but I was going to try and do that, and I wasn't going to do anything else. So I didn't write any of the other entrance exams. So as a general surgeon, I think gastrointestinal surgery is something we see a lot of. Surgical oncology in general, which means that you deal with breast and gastrointestinal malignancies. Those are all the organs that we're quite aware of and we operate around. But this was really something that we had no clue about. But I decided that however long it would take, however much of an uphill path it was going to be, that I wanted to do only that. And it's been a rewarding journey. So I did my MCH from Amrita, which is a wonderful institution in Kochi that specializes in this kind of work. And then I got to do a fellowship in Sydney with some amazing surgeons. And it's been a nice journey.
Wow. You described the way the doctor had done the surgery as if it is just like cutting some vegetable and stitching it back. Wow. It would have been really something. Great. Head and neck cancer surgery is not just about removing a disease. It affects speech, it affects swallowing, it affects appearances, and it could be making a difference in the identity itself, right? Was it completely something that attracted you to this specialty? That
Absolutely.
sorry.
Absolutely. So, I agree with you completely. So, I always liked reconstructive surgery as well.
Okay.
I trained in reconstructive surgery along with head and neck. So, I don't do any other reconstructive surgery like aesthetic or anything like that. But I found it fascinating the fact that you create these defects when you remove the cancer. And then the challenge for us is to try and restore the patient to a sense of normalcy. Because what happens is when you do a good job as an oncologist and you remove the cancer and the patient completes the treatment, some of them need radiation and chemotherapy. These patients actually do live for a long time. So they have a good life expectancy ahead of them, which is good. But the problem is with a good life expectancy, if functionally they're very poor, which means that their speech is badly impacted, their swallowing is impacted, their social functioning is impacted, then, they really suffer a lot. And that's something that, we have to be very, very cognizant of. So I think for us, one aspect is always doing better surgery from an oncological standpoint, which means that we do less invasive but equally effective surgeries. We do more radical surgeries that give the patients higher cure rates. But then that reconstructive process is also very interesting. So how do we restore that patient's form and function? How do we reconstruct the tongue so speech is almost normal? How do we make sure that our patients are eating normally? How do we give them a full set of teeth? So that's for us, equally important and something that we are always chasing.
So essentially, there is two parts to it, where one is removing the issue itself and then reconstructing it, where I think you have to plan both sides before starting.
Absolutely. So the thing is, only removing the cancer is part of the job. Reconstruction is also very, very important, right? Because our job is not to cure patients, but then make them social recluses where they can never leave the house. They can never enjoy a meal in public. They can't go out to a birthday party or a wedding reception. So we see this, unfortunately, less nowadays. But when you look at patients who were operated 10 years ago and 15 years ago and 20 years ago, very few of them are able to undergo that social reintegration. So for us, we're very, very cognizant of that, because it's extremely important that we allow these patients to continue to function. And for us, that's also an important milestone of success, not just curing these patients.
Wow. Doctor, India especially, right? It has a lot of oral cancers because of the kind of habits they have. What do you see in the ground reality today?
So, India unfortunately has a dubious distinction of being the oral cancer capital of the world in terms of incidence. We have a very, very high incidence of oral cancer. Now, a sizable amount of that can be attributed to tobacco and alcohol. So the latest survey, the Global Adult Tobacco Survey, showed that 1 in 3 adults, whether it's man, woman, rural, urban, uses tobacco, right? So that's a very high, percentage of the general population that uses tobacco, and something that we really have to bring down as a society. But what we see in India as well, and what we've published on, and what we've been trying to actually build more awareness about, is that 10 to 15% of the patients we have seen have never touched tobacco. So the tobacco awareness, with the campaigns in the movie theaters and things like that of these big grotesque cancers, are very important, and they've served their purpose. But they've also backfired a little bit. And the reason why they've backfired is primarily because people think if they've never touched tobacco, they can't get oral cancer, which is not true. And the second thing is that people think that once you get oral cancer, you can never function or look normal again. So ironically, what has, been designed to prevent people from using tobacco or make people quit tobacco use has caused a lot of people hesitating to take treatment, and a lot of patients, being in denial about the fact that they could have oral
Oh,
cancer.
okay.
So we see in practice a lot of patients who have never touched tobacco or alcohol in any form. But in India, we see patients with dental trauma. So people who haven't got dental checkups, who have bad teeth or sharp teeth that are constantly rubbing against the tongue or the cheek, that chronic trauma can lead to cancer. We see patients with ill-fitting dentures, again, that cause chronic trauma in the cheek or the tongue. Those can cause oral cancer. We also see patients who are on immunosuppressants. So patients who have had organ transplants, liver or kidney transplants, need medications to prevent rejection that they take lifelong. Those, medications can suppress the immune system and predispose patients to oral cancer. And then you have other associations like patients who live with HIV or human immunodeficiency virus. So we see a lot of patients with oral cancer, and not all of them have tobacco or alcohol. So the majority of them are still associated with tobacco and alcohol use. But it's important that we focus on the other causes as well. Primarily also because we don't want to raise stigma, right? So as doctors, there is no stigma for us. Whether you use tobacco or no tobacco, there's no judgment. For us, it's just like anything else, like, any other lifestyle or habit related issue you might have. But that stigma creates trouble when patients either do not admit that they have tobacco use and delay that diagnosis, or patients think that unless you use tobacco or alcohol, you can never get oral cancer. So both of these, unfortunately for us, are problematic.
Yeah.
So we try to build a lot more awareness about oral cancer and also positive messaging. So you see the movie theater ads about Mukesh and the horrible effect of tobacco and how he was dead in a few months.
Yes.
But the positive message that I would like to share is the majority of patients are cured. So majority of patients who come to us with local or local regional disease, which means there's only disease in the mouth or the neck, if we treat them well, vast majority are cured and go on to live meaningful life. So that's equally important for people to know. So in this quest to scare people about tobacco and make them aware of the harsh realities of tobacco, I think unfortunately oral cancer treatment has been thrown under the bus. So that's something that we need to talk about.
Definitely. I think the kind of ads that are being posted have to be remodeled into more positive and structured way of handling it. So, doctor, how does a patient, be it a tobacco consumer or a non-tobacco consumer, understand or identify that he or she is heading towards having a cancer trauma
So
cells?
in general, for anyone to identify cancer, the simple rule of thumb is to listen to your body. Okay, so all of us are not doctors. All of us don't necessarily have the requisite level of training to understand what's going on. But you need to listen to your body and figure out if something's been troubling you or going wrong for the last couple of weeks. Okay, so we all have acute imbalances. We can have, short-lived problems. But if these problems last for longer than 2 to 3 weeks, we really have to evaluate them. It doesn't mean that everyone who has a dental problem or an ulcer in the mouth will have oral cancer. Mercifully, it's not that. Majority will not have oral cancer. But you can rest assured that most of the patients who end up with cancer do have these problems. So what are those problems? You can have a red or a white patch on the cheek, on the gum, on the tongue that doesn't go away. It's there for 2 or 3 weeks. It's getting worse. It's getting bigger. You can have a painful ulcer, again on the cheek, on the gum, on the tongue, that's getting worse or not going away after 2 to 3 weeks. You can have some pain in the mouth. You can have blood-tinged saliva, either when you're brushing your teeth or when you're eating. You can have some loosening of teeth. So usually teeth are quite strong. They're sitting quite tightly in the jaw bone and they don't loosen on their own spontaneously. But if you have loosening of teeth and you don't have, a trauma or something that caused it, you should be a little worried about it. if you have difficulty opening your mouth, if your mouth opening is reduced, you're not able to open your mouth very well, or if you have a lump in your neck. So those lumps in your neck are usually lymph nodes.
Yeah.
So the lymph nodes can get enlarged if you have a tumor that has spread to them. So these are all the symptoms that we should be aware of.
Okay.
Like I said, if you've had any of these for more than 2 to 3 weeks, get it checked out. Majority of the people who have these mercifully do not have cancer.
Okay.
But when you look backwards, virtually everybody who does have oral cancer has one of these symptoms.
Right.
So it's important that you get evaluated and you rule out cancer and you get treatment. You don't neglect it for months and months, because another unfortunate bit of trivia from our country is that the average delay from the very first symptom to definitive treatment, which means when the patient gets surgery, for example, is 9 months.
9
Right?
months.
So you can imagine 9 months. So imagine that for any other problem in the body. Imagine if you slip and you hurt your knee, you have a dislocation. Imagine waiting 9 months to go to an orthopedic to get it sorted out.
It's
Right. So
permanent.
the reason, it's horrible, right? And the reason for that is a few. Number one is awareness. So people don't know what the issue is, right? They think it's a dental problem. They think that it's an allergy. They think it's everything under the sun. And sometimes physicians and surgeons can't identify them, right? So people who are not very well versed with the oral cavity, who don't examine the head and neck, who don't see tumors, might think that it's something else. And all of those end up as costly delays. People who live far away from, hospitals or healthcare services, wait till they're quite symptomatic, until they have a lot of trouble. Then they take time off of work and travel to a place for a scan, for a biopsy. So all of these things contribute. And the only way we can really reduce all of this is through awareness.
I believe you are also taking a great stand in terms of creating this awareness, right, Doctor?
Yeah, absolutely. I think the problem with head and neck is that it is anatomically very complex, right?
Okay.
So if I were to tell you that somebody had a breast lump, the first thought would be breast cancer, right? If you had a lump in your abdomen, the first thing somebody would think that it could be a cancer, could be my stomach, could be my intestine, could be my liver, right? But with head and neck, people don't make that connection. They think that you have a dental problem, you have an allergy, you have a toothache. They think about everything other than cancer. And they think that I've never used tobacco, I don't have any risk factors. There's no way I could have head and neck cancer. So we really have to break that thought process. And we have to be very clear on our messaging that virtually anyone can get it. Not to scare you, but the point is you pick it up early, extremely treatable, extremely curable. Vast majority of patients do well. So don't prevent yourself from getting evaluated. Don't delay that diagnosis out of fear or anxiety, because early diagnosis means high cure rates.
Okay, Doctor, you are specially known for handling high risk and complex advanced cases. So many patients come to you after being told that the cancer is not curable, it's inoperable. How do you evaluate such cases differently?
So I think it is very much a team sport. So I stand here basically as a representative of a very large team of fantastic people.
Okay.
Who work together in order to serve these patients to the best of our abilities. But some of the advantages that we have now that weren't available, say, 5, 10, 15 years ago, is the access, I think, to very high quality imaging, excellent intraoperative tools, which means the kind of energy sources that we use, the kind of fine machines that we use, to drill very small areas, saw very small areas, using a robot, for example, to avoid making a big cut in the jawbone to get to the back of the throat, for example, and having excellent ICU and post-operative care, we are able to do these surgeries routinely that wouldn't have been possible about 10, 15 years ago. And the reasons are a few. Number one is it was very difficult before we had that level of precision in imaging for us to understand what was operable and what was not operable, because we didn't have that clarity to understand where exactly the tumor was and could we remove it completely. We didn't have that ability to do those precise surgeries because sometimes we didn't have the tools, right? And the third thing is when we did those big surgeries, the anesthesia management, right? The ability to manage the patients during those big surgeries and for them to come out of that anesthesia and recover smoothly was difficult because of the kind of monitoring that patients required, the kind of development of anesthetic drugs and agents, and last but not the least, the rehabilitation. So the avenues that we have for rehabilitating a patient, so we get them back to swallowing, speaking, functioning, that is just incredible now, the kind of facilities we have at our disposal. So I think it's a multifaceted kind of approach to those kind of patients. Our thought process is if the patient has a reasonable chance of cure, if there's a good chance that the surgery will be a success, not only from a technical standpoint, which means that the patient should recover and go home, but also the patient should have a chance of a cure, which means that we should be able to remove the cancer and they should remain cancer-free for a good period of time, then we don't want to turn those patients away. So if the patient is fit and healthy and they want aggressive treatment and we think that treatment will be successful, our policy is to not turn patients away, which doesn't mean that we operate everybody who comes, because if we think that either we cannot remove the cancer completely or we don't think that the patient is going to have a good recovery, we don't offer surgery. So unfortunately, there are patients, beyond the scope of what we can offer surgically. But I'm happy to say that the majority of patients do well, and we are able to offer them meaningful surgery that gives them a benefit in survival and functionality, because we're able to reconstruct these patients in such a way that they won't be functionally crippled. It's possible that oncologists 10 or 15 years ago may have been able to do these big surgeries, and the patients may have recovered and gone home, but they would have gone home with a feeding tube and a tracheostomy and functionally very poor. And then, it doesn't feel like a success either for the patient or for the treating doctors.
Wow, this sounds very complex, and the head and neck cancer definitely sounds very complex. So, what makes it so complex? Is it because the brain is connected with the neck and it could impact the rest of the body? How is it?
A couple of things, yes. So one thing is the anatomical complexity, which means you have a lot of very important structures in a very small area of real estate. Right? So as you go to the skull base, you basically have a lot of blood vessels. The arteries basically carry blood from the heart towards the brain and all the important structures. And you have the veins that drain the brain and all the surrounding structures back towards the heart. And you have the cranial nerves and multiple other nerves that carry sensation and motor function, which means that as you get closer to those nerves, there's a chance that if you injure them, you might have issues with vision, you might have issues with smell, you might have issues with speaking, swallowing, all of those things. So level 1 complexity is managing those structures without injuring them and successfully removing the tumors. The second thing is, even if you understand all of that anatomy quite well, the tumor distorts that anatomy. So tumors don't follow a roadmap. They go wherever the path of resistance is least, which means very often they might be wrapped around these structures. They might be very close to these structures, and saving them is difficult. The third thing that adds complexity for us is that many of these patients get radiotherapy and then the tumors come back. So when we operate post-radiotherapy, what we call salvage surgery, that is much more challenging because the tissue quality changes. So radiotherapy does a great job at killing the tumors and the occult disease, which means whatever microscopic cancer cells we cannot see are effectively sterilized by radiotherapy. But the tissue quality changes. What that means is when those blood vessels get radiotherapy, the healing properties of the tissue change drastically, which means the patients have much worse healing.
Oh.
The chance of complications like bleeding and breakdown are much higher. So these are the things that we have to mitigate with and make the job interesting, let me say.
Make the job interesting. Wow, that's a nice statement. Doctor, I have a couple of questions here. I have seen while going in the traffic and places like that, I've seen somebody with a heavy external complex body around their face. What is that? Is it related to cancer or is it some kind of skin disease? What is that?
So do you mean like a flap? So what happens sometimes is we have to remove a large part of the face because it's involved by a cancer. So we have to think of this part of the face just like a gangrenous limb. Okay. So we have to remove that so that it doesn't take the life of the patient away. And also what happens is once it involves the jawbone or the tongue or whatever it is, most of the time that function is not coming back. So it's no longer a viable bit of tissue. So we have to remove it, right? We have to think of it like a diseased organ and we have to remove it in order to save the patient's life. So then we reconstruct with tissue from a different part of the body. So what we use now are called free flaps. So this is where we take tissue from another part of the body and we take that tissue with the blood vessels. So we usually use the arm or the leg. We take some tissue with the artery and the vein and we connect it to the artery and vein in the neck. So basically it becomes a living block of tissue. So the reality of what we do is that these structures in the head and neck are very complex structures. So if you look at your cheek and you look at your jawbone, right, you have skin, you have subcutaneous tissue, which is fat, you have muscles that control facial expression, you have the jawbone, you have the teeth. Now, when you remove all of that, it would be very nice for us to be able to replace all of those things, but very often we can't. We have to make do with a single block of tissue from the thigh, for example, to reconstruct all of that, right? So when we do that, again, it would be very nice, like we were tailors cutting a piece of cloth in precise measurements. It would be nice to make it match the opposite side. But we have a lot of limitations based on what that donor tissue is like. What that means is if the patient has a very thick thigh, if they're very muscular or they have quite a bit of fat, we have to take that tissue as it is. We can't take out the fat because the blood vessels go through the fat into the skin. So basically, if you have a very thick thigh and we're using your thigh to reconstruct, then unfortunately, it becomes like a big block of tissue. But what we do is, down the track, we can debulk it. So once it shrinks, this tissue generally shrinks by 30-40%. If it doesn't shrink after a certain period of time, say 6 months to a year, we can always reduce the size and make it match the opposite side a little better. But there are many restrictions that we have during the first surgery. And most of them are related to the body habitus, which means the patient's own body. So if you don't have much fat, then your flap won't have much fat. But if you're obese or you're very muscular or the blood vessel configuration in your flap is a little complex, then we have to take a chunk of muscle along with it. We have to take a big bit of skin with it. So there are a lot of limitations that we have to deal with when we are doing these reconstructions.
Wow. That sounds really interesting. Of course, dangerous too. Okay. Doctor, this may not be an oncology or a cancer question that I'm asking, but I heard a couple of my friends who told that when their colleagues were at work, not my personal colleagues, but my friends' colleagues were at work, they suddenly collapsed. One was in USA and one was in India. I mean, it happened during different time periods, right? But both of them had the same thing, something inside the brain, and that led to the death. And that was not even discovered till they had a postmortem. What is that?
So I think it may have been an aneurysm, I'm guessing. Not really sure about this, but these stories often make us very panicky and anxious, right? You have a healthy person who drops dead in the middle of a day without, any preceding cause or incident. Our first concern is to panic a little bit. But there are a few caveats here. The first caveat is thankfully having those problems are very rare. So we may know people who this has happened to, and it's, tremendously unfortunate that it happened to them early in life. They had a lot to offer and their lives were cut short by disease. But first and foremost, it's not common for those to happen, right? So aneurysms are basically little weakenings in the arteries
Okay.
or that supply the brain. So what happens is with that high pressure that the brain receives in the arteries, sometimes they can burst. But when they burst, there can be a bleed. And that bleed and that lack of blood supply to the brain can basically cause sudden death.
Yeah.
So when we hear that, it's important to realize that these don't happen to everybody. There's no reason for us to be panicky. But it's also important that we don't ignore symptoms. So it's not that everybody had no symptoms and they were always fine. Very often you can have some symptoms ahead of time. You can have some vague headache. You may have had some dizziness. You may have had sudden blurring of vision and you may have ignored it. So it's important that we don't ignore these symptoms because they could be something serious.
Okay.
Now, should everyone go out and get scanned? Certainly not, right? So there's no indication for us to go and get these invasive scans, for us to get, whole body scans or any of those things, because a few reasons, right? Because number one, the likelihood that all of us will have something wrong with us is quite low. Number two, when we do these scans for patients who have problems, they're very specifically designed to answer those questions, which means that if you have a headache and your neurologist or your neurosurgeon thinks that you could have an aneurysm, the scan that you would get of your brain would be very specific and very fine and precise to answer that. But when we go out and get like a full body scan, those slices are very thick and we may miss problems. So it's important for us to have general checkups. So after the age of 30, 35, it's good to have general checkups at least once a year,
Okay.
where we check on our general health, like blood counts and renal function. After you reach a certain age, heart checkups through ECGs and echocardiographies. All of these are very important. So it's good to see the doctor not only when we are in a dire strait or, an utter emergency. Getting regular checkups is really important so we can identify these calamities before they happen.
Okay, now coming back to the tumors. So some of the tumors, doctor, they are like the jaw, the airways, the skull base. Like as you mentioned, they're all close to the structures that are very, very positioned in a small real estate. How do you plan surgeries for this level of complexity?
So, number one is being trained. I've had the great fortune of training with some amazing surgeons who, I still reach out to and receive mentorship from and, exchange ideas with, especially when things are very complicated. So the first thing is to get trained well, join a place where you get exposure to this kind of work. You understand how these patients are managed. The second thing is to realize that there's a lot of expertise that goes into this and to work with people who are slightly different than you in terms of academic background and exposure. So what I mean is when we see a tumor, my plastic surgery colleague, my neurosurgery colleague, my cardiothoracic colleague all have different training, right? Which you would think would create trouble, but it's quite the opposite because we all have a different vantage point. We all have a different way of approaching the same problem. And the patient gets the best possible amalgamation of everyone's expertise. The third thing is that you have to keep yourself updated. You have to keep reading. You have to be aware of what is out there. And you have to basically keep honing your skills. Very, very important. And the fourth thing I would say is to remain humble, to keep learning and understand that at the end of the day, it may sound like we are doing something very heroic and the risks are all ours, but they aren't. The risks are the patients and the patient's family members and we have to be very cognizant of that.
Okay.
It's very easy for us to think of ourselves as the cowboys of yesteryears, those very heroic surgeons who would do these 18 and 24-hour surgeries, where the patient may never go home. But it's important for us to realize that treatment has to be patient centric, which means anything you do, however small a surgery or however large a surgery, it has to serve, that patient in a very objective manner. So either you have to take away their disease, you have to take away their pain, you have to make sure that they have a good chance of living longer. And when you are very patient centric, then you find a way to, I would say, innovate and push the envelope. So when you are sure, for example, that a risky operation will benefit the patient, then you find a way to make it happen, rather than the other way around, where you decide that, a bunch of other people have said they won't operate it, therefore I will. Certainly the worst thing we can do. But if we say that, okay, this patient is likely to do well, this patient wants aggressive treatment, how do we get from point A to point B? Then you start thinking outside the box, you exchange ideas, you use technology in new ways, and very often the universe conspires to help you out.
Wow, that's very interesting. You said you collaborate with so many other doctors who are in the same bandwidth as yourself. How important is collaboration under these kind of cases, these complex surgeries?
Absolutely.
Great. So beyond survival itself, doctor, how much emphasis do we have to, or yourself would put in on preserving like the functions and quality of life?
I think it's very important. So like Maslow's hierarchy of needs, in cancer we have a hierarchy.
Okay.
The bottom is oncological concerns, which means that we have to get rid of the cancer in order to increase the patient's life expectancy.
Okay.
Then you have the functional considerations, which means that you have to preserve the patient's speech, swallowing, taste, smell, vision. And then the top of that pyramid is cosmesis, which means how the patient appears, right? The ability to give that patient treatment without too much disfigurement. So you have that hierarchy of needs, which interestingly hasn't changed much in the last 100 years or so. So that framework still guides everything that we do. But the new, I would say, skill sets that we have, the new expertise we have, the new technology we have, allows us to achieve this with shorter hospital stays, lower complication rates, and overall less suffering. So we are still doing pretty much the same surgeries that they were doing 100 years ago, funnily enough. But we are doing them through smaller incisions. We are doing them with lower complication rates. We are doing them with a quicker return to normalcy. So we have patients with these big surgeries who go home on day 5, day 6. Many of them go home eating without any feeding tubes or anything, which was virtually unheard of, say, a decade ago. So all of these things, when you look at them, in a, I would say, in a complementary fashion, all of the progress that we have in terms of technology, equipment, expertise, anesthetic drugs, ICU care, all of this has really allowed us to make these patients, recover quickly and do a lot better and have longer life expectancy.
Great. Doctor, it's 4 p.m. Can we continue? Do you have time enough?
Yeah, no problem. No, I'm free. Go ahead, please.
Great. So one area where you work has been recognized worldwide, right? The joint day reconstruction. For listeners hearing this, what is it? What exactly is that?
So jaw in a day is exactly what it sounds like. It means that you get a jaw in a single day. But for a little context, what used to happen is when patients would lose their jawbone because of a disease, whether it was a cancer or other disease. Sometimes you can have trauma, you can have infections, you can have benign tumors. So very often part of the jawbone would be destroyed or damaged or had to be removed.
Oh my God.
So typically what would happen is patients would get some form of jaw reconstruction. earlier there was no bony reconstruction. Tissue from the chest used to be used to cover up that defect, but you wouldn't get the shape of the jaw, you wouldn't get that function. Then what came is bony reconstruction. So you can take the smaller bone from the leg called the fibula, you can take it with its blood supply, you can shape it into the shape of your jawbone, and you can put it in place with small plates and screws, or you can take basically bone from your hip and reconstruct that. And then what came next was implants. So basically dental implants are put into this bone, and then we can fix a set of teeth. So for a patient to go from removal of this tumor or trauma or dead bone to having a full set of teeth used to be a year or a year and a half. So initially the patient would get that reconstruction with bone. Then after a few months, maybe they would put in implants. And then after the implants had healed, maybe the patient would get a set of teeth. And there were multiple surgeries, unfortunately. So you would put in the implants with another surgery. And then you would have to adjust that tissue in the mouth to make space for the teeth. That would be another surgery. So a few things happen. Number one, the complexity goes up, the cost goes up for the patients, the financial toxicity and other things go up. Patients are fed up of treatment. They don't want to come back again and again for procedures, and it's not very accurate. So what you planned, the teeth to look like a year ago is going to be very different than what it looks like now, because I told you the tissues change, they contract, they shrink, all of these things happen. So what happened for benign disease, which is non-cancerous tumors or trauma or things like that, is they shrunk this whole process into a single surgery, which means that in a single surgery, you would get the jaw reconstruction, you would get the implants, you would get the teeth. So that shrunk that whole process down considerably. And it was a very attractive proposition for patients who are undergoing this kind of surgery. Now, this took off for benign disease. It's still very difficult to do in benign disease. Still not many people who do it in benign disease. But in cancer, it was virtually unheard of, because cancer has a lot of other considerations. So we're removing a tumor. The tissue that we remove is a lot more compared to, a bit of dead bone, compared to trauma, compared to all those other issues. The amount of tissue that we have to remove to cure the cancer is a lot more. Patients often get radiotherapy, which I told you creates problems with healing and recovery. And also the fact that these patients need to complete that radiotherapy within a short span of time. So they undergo that big surgery. We need to start their radiotherapy within 6 weeks, which seems like a lot of time. But when you undergo these big surgeries, it's not a long span of time. If the patient has a complication, if they have an issue, and that radiotherapy start date gets pushed, then there's a much higher chance of that cancer coming back. So when you look at all of those things, doing this procedure in cancer is very, very difficult. And having that background of seeing patients with cancer, having to remove a lot of jaw bones for cancer, this is something that we really wanted to do for patients with cancer. So we started this process off. My mentor in this is Professor Jonathan Clark in Sydney, who is a very world-renowned figure in jaw reconstruction, and I had the pleasure of training with him. I trained in that procedure, maybe about 6-7 years ago, and I came back and we started that. So it was a little different than how it was done over there, because of the availability of trained individuals. The availability of resources is very different. So they run on Medicare, which means the government pays for a lot of treatment. Patients are not paying out of pocket. A lot of this is reimbursed, which means that the government is happy to reimburse for all of this. Whereas here in India, it's very different. A lot of our patients have no health insurance. They're paying out of pocket. So we worked on this process a little more optimized for the Indian patient, a little more optimized for the Indian volume. So we do a large amount of head and neck cancer surgery. Me personally, and as a country, we do enormous volumes of this. We operate multiple patients in a day. So how do you take that process and shrink it down so that you continue to be efficient. You can't say that I will go from operating 50 patients a month, to doing only 10 because I'm doing complex surgery. What happens to the other 40,
Yeah.
right? You can't make them wait for an additional 1 week or 2 weeks because the tumor grows. So we worked with Jonathan. This was my idea, and he helped us work it out. And we published some papers, and we worked on it, and we streamlined the process. And we've been doing that successfully for a while. We published our data, which is, I think, the largest volume of JONA for oral cancer, and the results have been good. So we are able to offer this reliably to patients without much, economic burden. The cost compared to their cancer treatment is minimal. We are able to ensure that patients get good results. We haven't had anybody either having severe complications or having to interrupt their cancer treatment because of this. So we've got good results. It took a while for us to study this before we were talking about it. We wanted to be very sound about it and make sure that our results were good before we offered it to more patients. So that process was very slow. We do sometimes a couple of surgeries in a month now of this nature. But, the first 10 surgeries took us almost 3 years to get right, because every time you do it, you realize there are a lot of things you shouldn't be doing, and you refine it that much more. So we went from maybe 10 surgeries in 3 years to doing a couple a month now, because that process needs to be painstaking. You cannot experiment with patients who have cancer, and your margin for error is very low. So we went through that painstaking process, but I'm happy to say now that we are quite comfortable and confident offering it to a good number of patients, and the results are good.
So, doctor, you said in Australia the procedure is a little different from what you have adopted here. What is that?
Yes. So there are a few things. We don't honestly have access to all the expertise that they may have in a high quality center like the one that I trained in. So like you have a center of excellence in India, the place I trained is probably the best hospital by far in Australia that has a lot of resources, not only in terms of financial resources like 3D printing labs, but also human resources. So you have excellent, prosthodontists, you have virtual surgical planning engineers. So these are engineers who help us do the virtual surgical planning, which means we take the patient scan, we run through the entire surgery like a mock surgery. We decide what part of the bone goes where. We check the angles, we put in the implants, we run various simulations to see what the best permutation and combination is. So the kind of expertise we had access to, the kind of resources we had access to is very difficult when you come back to India. It's not that you don't have excellent people. It's just that they may be scattered all around. You may not have access to resources. The patients who you are doing these surgeries on may not have great insurance cover. None of this may be reimbursable, which means they might be paying out of pocket, which means that you have to do it on a much tighter budget. The back and forth that we have, if we do a 3D print and we're not happy, you could probably throw it in the dustbin and start over again. We don't have those luxuries, right? So I think there are a lot of restrictions when you want to make this accessible to everyone. If we were only offering it to people who, have been blessed and have a lot of resources, have no dearth of, either insurance or money that they have to spend on these surgeries, it would be very different. But that's certainly not what we wanted to do. We wanted to basically make it available to everyone. So those restrictions became a lot, more apparent to us. But I would say that the net result is that we got a lot more efficient. So we don't need that much money. We don't need that much time. We got more efficient at doing it, within those constraints, resource and otherwise. And I think now we are able to proctor other centers to think about doing these surgeries and offer them to patients. And I think at the end of the day, that's what we want. We want to make this more accessible to patients. We want patients who are functionally better after these surgeries we want to try and restore them back to how they were before the disease affected their lives.
Wow. So, how transformative is it psychologically for the patients to value up? Yeah.
It's massive. So we've seen two different scenarios. The first scenario is you remove the jawbone, patient gets some kind of reconstruction, their speaking is impaired, swallowing is impaired, appearance is altered, they don't have a set of teeth, the lip is collapsed, face is drooping. It's very difficult for them to get back to social functioning. It is really hard. How much ever you try and cheer them up, whatever tools you give them, psychological and otherwise, it's really difficult for them to get back to that style of functioning, how they were before the disease affected them. And the second patient gets a full set of teeth, wakes up from surgery with a full set of teeth, talking, speaking. So there is, with no scars on the face, there is virtually no comparison. So these patients don't suffer that functional loss that the first group of patients did, where they would go months and years possibly without any kind of rehab. And it changes them, unfortunately, because this disease changes not only the way other people see us, but the way we see ourselves, right? So our identity, unfortunately, is tied up into the way that we look and the way that we speak and we function around others. So it's really devastating when we are able to cure young patients who are going to live for 30, 40 years, but cannot return to the workforce, cannot, enjoy a social function out. So that's nothing more important to us than kind of restoring that.
Okay. Doctor, the jaw that you said is going to be replaced or reconstructed.
Yes.
Would it be a lifetime thing, or would there be a...
It is. It is. So the advantage of using living tissue, connecting the blood vessels, is it's a functional organ. Okay. So what that means is that the blood supply is intact. It will stay there, barring any complications, which maybe are about 2-3% of people. The flap is there for the rest of the patient's life and it doesn't give you any trouble. It's different compared to implants. So there are things called patient-specific implants where we print out titanium and we use that to replace the facial skeleton. Okay. So those have a lifespan, no different than a hip replacement or a knee replacement. They may last for 10 years, 20 years, but they don't last forever. So most of what we do for our patients and what we do for all of the cancer patients is we do reconstruction. So we use free flaps, use their own tissue and reconstruct. So that stays there for life. We don't have to take it out. We don't have to do anything and it stays put.
Wow. 3D printing, removal of the tissue, reconstruction, so much of technology, and
Absolutely. I think we have benefited so much from the rapid infusion of technology into the practice of medicine. Okay. Right? So the people who help us do this work are actually engineers, right? So they're not doctors. The people we work with, they are engineers. Most of them work in video game design, and they're the ones who help us do this virtual surgical planning. Yeah. So now more than ever, I think it's important for us to realize that doctors are important, nurses are important, but there's also so much expertise that we get from other specialties. And it's time that we really leverage that expertise and, that teamwork in order to get the most out for our patients.
So at the end of such surgery, doctor, what defines success for you personally?
I think there are a few things, right? So being patient-centric. Unfortunately, that you can't cure every patient. We wish that we could. We cure the vast majority of patients mercifully. It is a disease that we know how to treat pretty well. But what is important for us is to know that we've done the best for every patient. So we've gone beyond what the basic requirement is. We've done our very best for the patient. Unfortunately, many times in surgery, there are things that are not in our hands, right? They're non-technical issues, the patient's own health. There are a lot of things that are not in our control. So whatever is in our control, we want to be, maniacally meticulous about that. We want to do the very best job we can do. We want to be very disciplined and organized in whatever we do for the patient. And we want that success to be repeatable. So what that means is we want to do the best technical job we can do, but also take care of the patient as a whole, which means be very cognizant of what they're going through, focus on functional issues. So very often, I think maybe when we were probably less mature, had a lot less white hair, we would think of surgery only from the technical aspects, right? We would think, okay, we're going to replace this jaw with the bone from the leg. But the patient's consideration might be speech, it might be appearance, it might be the psychological impact of a surgery. And we have to be very attuned to those things, right? It is not a mechanical job, it's not carpentry. So you have to look at the patient as a whole. You have to learn to listen. It's very important to listen to the patient. Worry about what they think is important and not what you think is important. And then what you realize is if you generally follow these rules, I think that's what makes you successful. So your patients are happy. They're satisfied with the treatment that you've given them. You're satisfied that you've done your very best. Everything doesn't always go your way. But if these are your guiding principles, most of the time things will be good and you will be satisfied.
So, doctor, these patients whom you have operated and their extended families, do you also give them a therapy about what they can expect and how to handle the post-surgery situations?
Absolutely. So, it's very important for us as oncologists to be aware that nearly 30% of patients who are diagnosed with head and neck cancer have anxiety or depression related symptoms. So a new diagnosis of cancer leads to depression or depressive symptoms in at least a third of our patients. So we have to be very keen to pick these up and identify patients who might be depressed and make sure that they get formal treatment for that. You know, it could be counseling, it could be medication. It's very important for us to be honest with our patients, right? I wish that we really could 3D print a jaw with teeth and muscle and nerves and vessels. We aren't there yet. Maybe we will be in our lifetime. We'll be happy about that. But we have to be realistic about what we're trying to do. We have to be realistic about what the patient can achieve. And they have to be comfortable with that plan. Because if you tell a patient whom you're removing 3/4 of the tongue in because of a cancer, that you're going to be speaking and eating like nothing happened in 2 weeks, they're going to be very upset. They're going to be very, disappointed. Then how do you deal with that? So I think honesty is important. You don't want to sugarcoat, and you make them realize that there will be problems, there will be road bumps, but you'll manage them together. So what I like to tell patients is, there are complications. Thankfully, not everybody has complications. But we talk about all the complications because if they arise, we have to navigate them together. So I don't want you to be panicky and anxious if you do have a complication. We will navigate that together. We'll take care of it. But I want you to be aware. I want you to be empowered. And I want you to be positive about the process. Nobody deserves cancer, whether you smoked or drank or whatever it is. There's no logical reason why anybody should get cancer. So all we can do is offer you the best treatment and offer you the best support, and let's navigate our way out of this.
Okay, doctor. So technology has made a lot, like it has changed a lot the way head and neck oncology is being seen now. What advantage does TORS offer compared to the conventional open surgeries?
So transoral robotic surgery is, I won't say new, it's about 20 years old, but it's been remarkable. So what transoral robotic surgery is, it's basically the use of the surgical robot to operate in the back of the mouth. So we can access the mouth very easily with normal surgery. If you open your mouth, you see your tongue, you see your jawbone, we can access all those areas. The difficult parts of the mouth and the throat to operate are in the back, right? So the back of the tonsils, the back of the tongue. These are the areas which we cannot easily access because they're hidden, because there's a lot of tissue in between us and those areas. So what used to happen to access those areas is what's called a mandibulotomy. So that's a controlled fracture of the jawbone in order to open the jaw like a book, operate in the back of the throat, put the jaw back in place, wire it shut or put in plates to fix it like a fracture. Patients would need a breathing tube, a feeding tube, all of those things. That recovery was maybe a couple of weeks at best, right? So that was a required. So to be very clear, I won't call it barbaric, but it was required because that's how we would access those tumors. That was the only way we could get to those areas and operate safely. With transoral robotic surgery, we are able to dock the robot inside the mouth. We're able to access these areas with very small instruments. So if you've seen a robotic instrument, it's very small. It's much smaller than our finger. And basically they're wristed instruments. So that means the instruments move around and function no different than our hands do. In fact, a little more efficiently and accurately than our hands do.
Okay.
We're able to access those areas without any of that so-called barbarism. So we're able to operate in the back of the throat, remove tumors from the back of the tongue, possibly go up into the skull base and come out. So what that means is patients don't need the feeding tube very often. They may not need the breathing tube and they go home in a couple of days. So there's no comparison between, the pre-TORS era and the post-TORS era. The amount of recovery that the patients are spared, the amount of complications and suffering and pain and dysfunction that patients are spared is remarkable.
So all this, and you also mentioned that you work with a lot of engineers and technology to get things done. So 3D surgical planning is quite important here. And
Yeah, absolutely. It's something that we use quite often. So like I said, we take a scan of the patient and we do a mock surgery. So we decide, okay, this is the part of the face that we need to remove because it's involved by tumor. And if you look at all of our faces, they're different, right? So my jawbone, your jawbone, someone else's jawbone are all different. It's not a one size fits all. So we use basically a mirrored approach. So we use the opposite normal side of the patient's face in order to figure out how to reconstruct it. So we will match the patient's normal upper jaw to the abnormal side, and that will give us the angulation and the projection.
okay.
That will give us the position and the size of the teeth. That will give us the facial shape. So we do this process. It allows us to make a lot of mistakes without causing the patient any suffering. Because we've all learned how to do this without computers and without virtual surgical planning, the conventional way. But this allows us to do all of these things, to troubleshoot, to realize between multiple options which the best options are, to reduce the duration of the surgery and to be more accurate, and to end up with a lot better outcomes.
Nice.
So it's wonderful for patients. It's also wonderful for people who are training in the specialty now, who are coming into the field, because that learning curve for complex surgery will shorten significantly. So when we were training without any of these things, we never had the confidence that we would be able to do any of this. We thought it was going to be an enormous amount of time for us to learn how to be any good at any of these things. But now with that computer-based modeling and simulation, you can learn a lot more from every patient, a lot more from every case, and patients don't have to suffer our learning curves.
So that's quite interesting. So, Doctor, how do you see AI playing the biggest role in all of this in the next decade?
I think it's very important. I think there is, a lot of hype about how AI will replace surgery, surgeons, all of those things. I'm a little skeptical about that. But I think that if we use artificial intelligence to do our jobs better, it's a very, very good tool. What I mean is, if you look at diagnostics, so like diagnosing oral cancer, if you give artificial intelligence a very specific problem, right? You use digital pathology or cytology, and you train it to identify cancer and tell you, yes, is this cancer? No, is it cancer? Answer a very specific question, and you feed the system enough data, it will be very good at answering those specific questions. So similarly, for virtual surgical planning, it's nice to look at auto segmentation. So what that means is the initial plan that we have, the system can come up with that. So it can give you a few alternatives of how you would want to shape the jawbone, for example, and you can pick and choose. But it's unlikely to be a panacea in the kind of work that we do, because the work that we do is fraught with uncertainty.
Yes.
Right? So the problem with surgery is that no two patients are alike, no two tumors are alike, and you don't really quite know what the problems are until you know what the problems are. It's very difficult for us to navigate those issues well ahead of time. So I think artificial intelligence for surgeons has a great role. I think if it can help us identify variant anatomy, so if it can flag problems for us that we don't see, it can help us be more efficient about our surgeries. So we have tools now that analyze our surgeries and can tell us, this was a part of the surgery that wasn't very effective. This was not very efficient. This bit of operating was dangerous. That's a wonderful use of artificial intelligence. So I think having augmented surgeries is potentially where we should be in 10 years, where you have like a co-pilot that is telling you, this is the area where you should be careful. This might be where the blood vessels are running. This is how you should plan your surgery. So I think if we can use those tools to become better at our job, marvelous and nothing like it.
Nice. You're globally renowned neck and head surgeon right now, oncology surgeon right now. So what differences do you see in Indian healthcare system and global cancer care systems?
So quite a bit. Let me put it this way. India is probably not one country, it's many countries, right? So when I speak to colleagues from around the world, the best analogy I can think of is the European Union. So India is like the European Union, not only in terms of ethnicity, language, culture, also in terms of things like access to healthcare, resources, access to trained individuals. So if you are a person in India with resource, right? So if you do not have an issue paying for treatment, you can get the best treatment in the world, right? We are on par with any, top-notch institution anywhere in the world. I strongly feel that. But the problem comes for the people who are at the bottom of the pyramid. So the issue is for people who don't have access to healthcare. They don't have access to insurance. They live in remote rural areas. They don't have surgeons who need to do these kind of surgeries. They have long waiting lists. So that is where the trouble is. So I think we should be using, technology and artificial intelligence to address these problems, right? So the good thing about India is we have economy of scale. We have enough patients that we can do expensive treatment, expensive diagnostics at a much lower cost than anywhere in the world, simply because we have that volume of patients and burden of disease. So we need to start looking at India as a whole. We need to start looking at, for example, can we triage these patients? So for patients, for example, can we reduce the time to diagnosis? So that's something we've been working on. We have a grant for that from the NIH. Can we reduce the delay in treatment? Can we identify patients with cancer earlier? That means that they get, referred to the right team of doctors who will treat them early. Can we identify patients with disease that can be treated locally? You look at hospitals like Tata Memorial. People come from all over India to get treated, which is wonderful. It speaks volumes about the quality of work and the care that they provide. But do patients need to travel all the way from anywhere, any corner of India to Tata Memorial for cancer? Probably not. So can we triage these patients so we identify those without very complex problems who can be treated closer to home, who have, doctors, surgeons, oncologists with the capability to treat them much closer to home. So these are the kind of things that we should be looking at in India. How do we address this problem? Because if we sit in our ivory towers and only worry about the patients who come to us with resources, it's very easy for us to forget the problems of the masses. But, as doctors, that's not where we should be. We definitely need to worry about access, equity, affordability. And I think that it's only through partnership, through public-private partnerships, through collaboration that we can really ensure that at least the majority of patients get what they need.
Yeah, that's very true. The private and public sector has to collaborate to ensure that the masses get the same kind of treatment. So, doctor, what changes do you think, apart from this, that India still urgently needs in oncology?
I think India needs a much stronger primary healthcare system.
Okay.
So there are two things, right? So like I told you, the 9-month delay from the very first symptom to treatment shows us that the referral pathway is broken. What happens to patients? Either they neglect it because it's not a big problem, or they go to a doctor who may not know what the problem is, gives them some medications, or they go to a pharmacy who gives them some medications without ever being seen by a doctor or a dentist. That referral pathway is broken. So the net result is patients don't get the treatment that they need. If you also look at other BRICS nations, India spends the maximum amount of money on an oral cancer patient compared to any of the other BRICS nations. And why is that? It's because the majority of our patients are advanced stage disease. If you pick up an early stage cancer, the treatment is very simple. Patient goes home in a few days with a 90% cure rate. You pick up a patient with an advanced stage cancer, it's a surgery like the one I told you about. They're in the hospital for 5 to 7 days. 6 weeks later, they need radiation and chemotherapy. That radiation goes on for 6 weeks to 8 weeks. It's an enormous amount of resources spent on that one patient. So we need to start thinking. In India, we tend to think of tertiary and quaternary care. We think of bigger and bigger hospitals, fancier and fancier equipment, whether we are in the public sector or the private sector. It's not specific to any one area. But I think that unless we really realize that we need to build out a better primary health setup, where patients have access to doctors, they get these life-threatening problems picked up early, and then they get referred to specialists, the system is going to constantly be overworked, overburdened, and stretched.
That's right. They have also built departments and oncology programs. Sorry.
Absolutely. So the best thing that we can do is, we are very happy when we train fellows and other surgeons who go back to their part of India and practice there, so that patients don't have to travel all the way to us for, routine work. Unless patients are require very complex surgery, we're very happy for them to not travel, for them to get treatment closer to home. It's easier, it's cheaper, it's much more comfortable for them and the people who are accompanying them for treatment. The out-of-pocket expenditure is less. They're not looking for a patient place to stay, So we have to build, more distributed networks. So patients are able to get good quality care close to home. If there's a certain complexity level, then do travel. It's not easy for us to build very, very complex care teams for every corner of the country. That's another enormous waste of money and effort. So we need to be able to build systems that serve the patients a lot better than they are right now.
So how important, when you have to deal with so many kinds of teams which are both multidisciplinary, interdisciplinary, and you need to set up teams across where you have set up programs, oncology programs, how important is culture inside such high performing surgeries?
Extremely important. I remember my mentor, Dr. Subramaniam, who was my teacher, and it was a funny conversation that we had. So in the first couple of weeks of my training, so we are seeing them do complex surgeries all the time, and we were seeing them do, crazy surgeries that we had never imagined. And he called all of us. He called me and my colleague, and he's like, what you're going to learn with me over the next 3 years is how to be a team player. Don't ask me how many surgeries you're going to do. Don't ask me, what complex cases you'll be able to manage. I don't care about any of those things. But if there's anything that I will teach you in 3 years, it is how to be part of a team, how to work well with others, and how to get the best out of everyone for the patient's sake. So at that time, I didn't understand it. My colleagues didn't understand it, and we were a little perturbed. Like, we came here to work with these world-class folks and learn how to operate, and it didn't make any sense. But years down the track, you understand that you can have very technically skilled and competent people, but if they don't work well with others, the patient is not served. So at the center of all of this is patient care. It's fundamentally different than many other things, many other disciplines. At the center of, all of this is the patient. Therefore, we have to leave our egos at the door. We have to leave all of our preconceived notions at the door. And that is how you get more out of the team than any of the individuals.
Nice.
It is when you have this culture of being able to speak up. When you disagree with something, you think there's a better way to do it, even though you're the youngest and most inexperienced person in the room. This is how you get, the most, high quality output from everyone. And everybody feels that belonging and ownership, and they go beyond what is expected of them. So that's how you get these miraculous outcomes. It's not one person's individual skill and delegating little bits of, little tasks to everybody. That's not how it goes. So you let everybody do the best work that they're capable of doing, and then you see the miracles unfold.
Sure. So what qualities do you value when you choose your team, doctor?
So I think it's very important to be technically sound when you're doing complex surgery. There's no doubt. But I won't say it is the only factor that matters. So I'm happy that everybody I work with is approachable and down to earth. They're all nice people. They're not short-tempered. They are not, difficult to work with. You want people who are honest, and you want people who are realistic with the patient, not, sell big dreams to the patient that are ultimately going to disappoint them. You want people who are committed to the idea of working as a team. So a lot of this virtual surgical planning, all of this comes out of our free time, right? So we are all sitting at home or in a car on the way home at 7:30 or 8 in the evening, tuning in, rotating screws and plates here and there. You want people who are, who see the value in doing this for the patient. So it's a lot of things, But if you're lucky, I think if that is your attitude, you will attract people with the same attitude. And that's what I always believe. So when you project that into the environment, you get wonderful people to work with, and you learn so much by working with them.
Very true. Very nice. Yeah, you attract what you have inside. That's true. Head and neck cancers affect some of the most personal aspects of the life. Like you already mentioned that you give that kind of a therapy to the patient, and has there been any patient story that has stayed with you for as much as years possible? There might be many.
I think there are many, but I think the underlying thread is very simple. I think that once you realize that patients are human beings, once they realize that we are human beings, and they understand that you are doing your best, I think everything is smooth sailing. It takes a lot to put your life in another individual's hands. And I don't mean that to sound dramatic. What I mean is that when you tell somebody that there's a chance that their life could end on the table, which is a reality, unfortunately, right? We really wish that it doesn't happen. It hardly ever happens. It's very rare. But it's not fair to not tell the patient that it is a possibility. So in order for you to agree to that, right, and to be vulnerable enough with someone, you have to know that your best interests are, in their heart, number one. and you have to know that they're honest about what they're trying to do, and they will always put, your interests above everything else. And I think that is something that that understanding has really shaped the way that I interact with patients now, right? Because initially you think of surgery as very technical. You think that it's doing an operation and, being successful in that operation, a patient going home. But you realize that many times there are things that are not in our hands. And you have to be honest about that. You need to be humble about that. And I think that bond with the patient is sacred. And the irony is, even patients who don't make it, patients who have had recurrences of cancer, patients who have died, their families have come back to us and spoke to us and, message you on death anniversaries and things saying, we miss him, but we know you took care and, we're just thinking of you. I think that's enormous. So that makes you realize that you're a part of this journey, right? You're very much a part of this journey for them, and you're a significant part of that journey. So it's really important for you to think about that. Every time you plan somebody's surgery or you make any treatment decision, it's very, very important that we never forget that.
So, doctor, a few quick questions, maybe one word or a sentence, right?
Sure.
One innovation that you feel redefined cancer surgery?
I think virtual surgical planning, no doubt.
Okay. One thing people should stop ignoring about their oral health?
Ulcers, ulcers in your mouth, don't ignore them if they last for longer than 2-3 weeks. Get it checked out, get a biopsy. Hopefully it's not cancer, but don't neglect your dental issues. Don't neglect your dental issues.
A most underestimated aspect of recovery?
Psychological. Everyone worries about, your ability to swallow, speak, all of those things. But our job as oncologists very often is a coach, and I tell people that. So, imagine trying to run a marathon when you're not in the right frame of mind. So we have to think about that. We have to get patients in the right frame of mind for major surgery, and we need to motivate them so that they go through that. So I tell them that we have everybody. We have a speech therapist, swallowing therapist, physical therapist. We have everybody, but they can't do the work for you. They're here to help you and guide you on that journey, but you have to walk that journey on your own.
Nice. Surgery or research, doctor? Which one excites you?
Equal. You can't have one without the other. So you do research because you do surgery, and because you realize your surgeries aren't as wonderful as you thought they were. You come back with clinical problems, and that drives your research. And your research is what makes your surgeries better. So you can't have one in isolation. It's not fulfilling.
One word that defines your approach to medicine?
I'll say innovation.
Wow.
I think we're just focused on so I can just say that as a team, we are maniacally focused on doing things better, right? It can be something small that's been done the same way hundreds or thousands of times for a long period of time. But one strength that we have as a team is that we deconstruct everything. So we go in with no assumptions. We break down everything into the sum of its pieces, and we look at everything and say, can we do this better?
Wow. Great, doctor. Thank you so much for this incredibly insightful conversation. It was not just about cancer, about psychology and how recovery is important, all of that. And innovation, of course.
Thank you. It was a wonderful conversation, spanning a lot of topics.
I know.
Thank you for the questions and for the interactions.
Thank you so much, doctor, for being patient enough to answer all my questions also. And I'm sorry.
Most welcome.
Yeah. Thank you so much for taking out this time.
My pleasure. Thank you.